Hello, everybody. It's Ken Varner, the Director of Medical Education for Zimmer Biomet Dental. Welcome back to the 11th Annual Implantology Week, brought to you by Zimmer Biomet Dental and New York College of Dentistry. We've had a great week so far. We've had lectures from Dr. Christian Coachman, Dr. Dennis Tarnow, Dr. Marco Ronda, and we're going to keep that going with a great lecture from Dr. Sascha Jovanovic. He's going to be lecturing on soft tissue management and grafting to promote implant health and aesthetics for the long term. Before that lecture starts, I still want to encourage you to look around, sign into the hub a little bit early or stay a little late. There's some great product booths from DSD, Implant Concierge, Itero. Also, there is a poster project booth. A lot of people worked really hard on some posters and some ideas and some scientifically backed concepts. Please, when you get a second, come back in and review the poster projects. Above and beyond the poster projects, each presenter actually took 5 minutes of their time to create a video explaining the concept. So without further ado, let me introduce you to Dr. Michael Ursu.
Thank you, Ken. I'd like now to introduce Dr. Sascha Jovanovic and read his bio. Dr. Jovanovic was formerly trained in periodontics at the UCLA School of Dentistry, in implant dentistry at Loma Linda University, and in prosthodontics at the University of Aachen in Germany, and holds a Master of Science degree in oral biology from UCLA. He is the past president of the European Association of Osseointegration and a past board member of the Osseointegration Foundation. He is an honorary member of the South African Society of Periodontology and the chair of the EAO 2000 Scientific Congress, as well as an award recipient of the American Academy of Periodontology, the California Society of Periodontics, and the German Implant Society. Dr. Jovanovic's clinical research emphasizes aesthetic management in dental implant therapy and bone and soft tissue reconstruction techniques. His applied research focuses on bone regeneration with different bone materials and graft materials, growth factors, and barrier membranes, as well as the biology of soft tissue around teeth and implants. He lectures extensively worldwide and has published over 65 articles and book chapters and 1 textbook. He is the editor-in-chief of the Guide Academic Curriculum, is on several editorial boards for scientific journals, and presents and teaches his implant protocols globally. He restricts his clinical work to dental implant therapy and bone and soft tissue reconstruction, and is the founder of the academic chairman of the GIDE Guide Institute and the assistant professor at Loma Linda University. So now I turn it over to Dr. Jovanovic. Welcome, doctor.
Hello, ladies and gentlemen. This is Dr. Sascha Jovanovic coming to you from Los Angeles. And first of all, I would like to thank for the kind words from Dr. Mike Urso. My pleasure to be here. My pleasure to have worked on being together with NYU, with especially Ken Beecham, which I've known for many years. And, I want to appreciate or send my appreciation for him to include me in this program. I know there's many of you from around the world, Europe, Latin America, North America, who are logging into this here and who are participating in this global conference at NYU, although very few of you are probably in New York, but the same with me. We would see each other in New York, but now because of still the continuing health crisis, we're all in our own locations. So my lecture today will be on mucogingival as well as GBR procedures around implants. And my goal is to show you longevity. So how can you really be successful with implants for a long term? And how can you have aesthetic results around the implants, especially, of course, in the anterior part of the jaw, which many patients, are looking for today, not just their functional results, but stable long-term results. So I send you my greetings from Los Angeles. We're still like in a beautiful sunny blue skies during the day. So the palm trees are still waving, although of course our restrictions of moving around because the pandemic are there. Still many businesses are closed, but we are, of course, like hopefully regaining some positive energy and positive health over the next period. We are in the office, which is the guide office and the guide practice and the guide institute, so the learning institute, and that's in the western part of Los Angeles in Santa Monica. So we have a training center here, although that's really now more or less closed, but it's reopening in 2021. And we have our first training programs scheduled and registered, so that's good. Yep. We're getting there slowly. And hopefully, of course, I will see you at our next opportunity. If you want to stay in contact with me or with the Institute, guidedental.com, of course, is the Institute's website. And all the educational programs we have is on there. All the online education, all the online master classes, and all the online residency programs you can find there. Instagram and Facebook, let's say our primary social media. I gave you here the Guide Dental one and the Dr. Sascha Jovanovic one. And Facebook, I gave you also the Guide Dental Institute one and the Sascha Jovanovic one, which you can access at your own point. Then I have a couple of goals which I like always to bring forward, especially in these shorter presentations, because I live by those goals pretty much daily in my practice, and it also explains to you a little bit, how I work with colleagues and with patients. So my goal is to really, and I'm going to mix them a little bit, pay attention to every detail that I do. So if it's a lecture, if it's a patient care, we pay attention to every detail. Of course, I come in it with a longer experience because I've been involved with implants for 35 years from when I kind of was still in dental school. But that's really important. I try to focus at least from the beginning of the work to the end. So I don't drop or take a shortcut. And if it takes longer, I'll take longer. I try to do the right thing, which means I don't really use copy products or some other things which could compromise the result. I use the real scientifically proven tools and biomaterials. And the last one, which I put as the last, is I try to be a perfectionist if I can for my patients. Although, of course, as you know, to be a perfectionist is almost impossible. We try to gain that all of our life, but it's still, every case is a new case. But these are some of the goals that I have and which, of course, help us in our daily practice. Now, when I look at, soft tissue and bone, you can see just one clinical slide, which is very important for me. It's the soft tissue health that I try to create. Being a periodontist, as one of my foundational educational backgrounds, I believe in health, and I believe in soft tissue, and I believe in keratinization. And I believe that helps me with stability, and it helps me with aesthetics. And so here you can see how 4 implants were placed in the anterior maxilla, and I've achieved all this: thickness, keratinization, stability, and aesthetics. So I try to do that for every single patient. Now, when you look at, soft tissues, not every soft tissue needs to be created with implants, and sometimes Pontics and non-implant sites can be better. This is a case which is close to about 20 years in follow-up, and you can see the crestal bone stability, one of the most crucial parts of stability. And this crestal bone stability was achieved with guided bone regeneration to widen the ridge. So you can see here 2 extremely important parts for my implant success. It's the bony foundation, which usually I recreate or create with guided bone regeneration. And then secondly, the thickness of soft tissue with keratinized gingiva to create this emergence profile, which makes it so absolutely beautiful. And then you can see here in the view of this here that Pontic sites are definitely something which is part of implant prosthesis. So they could be an implant bridge, 3 unit, could be 4 units, could be like something even longer. But Pontics with good bone and good soft tissue can create aesthetics as good, if sometimes not better, than an implant emergence. So keep always that in mind, that everything we do today, and which I'm going to be presenting to you, I always think also like, is it just the implant we're trying to recreate with bone? Is it just the soft tissue we're trying to create to be supported with bone and an implant? Or is it just a Pontic? So that's kind of a variance that you can do for your patients. Now, what's really important when you think about periodontal structures, on the left side is a Japanese patient, so Asian patient, which has natural teeth, nothing was touched. It's all natural, patient's health, and no modifications done cosmetically to it. But pay attention specifically to the mucogingival line. You'll see a beautiful scallop which has come in. You see a beautiful mucogingival line which has come in. And you see a really full structure of the gingival papilla. Now we move forward to the right side of the screen, and you see peri-implant soft tissue. So this is a completely rehabilitated and reconstructed upper previously edentulous jaw. And you could compare left and right, and you might say, yeah, maybe it's ceramic that I'm looking at on the right side, and you're looking at zirconia framework bridges with a layering of ceramic. But look at the soft tissue, how, again, it has this scallop. Look at the mucogingival line, how it's positioned. Look at the gingival papilla, which is fairly full. So it replicates and it moves into that territory of natural gingiva quite beautifully. But in the difference between these two, as you can see on the left side, the tissue is quite thin. You can almost see the roots shining through. On the right side, you don't see that. So there, we're making sure that there's a lot of bone and a lot of soft tissue thickness right in space there. And that's what we, of course, need for these patients. So there's a lot of thickening procedures done here in that one patient. Now, when I move forward and I continue with implants, you can see I put here 2 cases which I both worked on, on the left side the patient came in like this. The implant, as you can see here, is not covered by bone. You can see that in the cross section of the cone beam CT scan, and you can see how already it's pushing through the buccal bone plate and almost pushing through the soft tissue profile. So even there's one area of the implant which is somewhat exposed. If you compare that to that right photograph which I showed you earlier, you can see how the right one doesn't show any grayness of titanium, doesn't show any titanium surface exposed. It's all covered by bone and by soft tissue. So what went wrong in the left one, and that's why the patient was sent in here, not the aesthetic restorations, which maybe are a little bit too big in my eye viewpoint, and too kind of bulky in my viewpoint, and there's absolutely no translucency in the ceramic. But okay, those are all details which some patients like it like this, some patients don't. But I'm looking here at the health, and you can see that the health of this anterior implant, it's it's short-term lived, because it's got to be, when can this be, how long can this stay in place? Now, some of you might think, well, can't you just do a soft tissue graft and put a nice thick soft tissue graft on the facial of this implant, cover the exposed titanium, and let it simulate that it's thick? Well, you could sometimes, but that implant needs to be in a more palatal position. If the implant is also pushed towards the buccal, like this one is, you're outside of the bony envelope. Outside the bony envelope, nothing really will stay for a long term because it's not in a natural biological position. So this implant is outside the bony envelope, which means it will live as long as it will live before an infection will happen or an abscess or etc. So this is not very good from a standpoint of patient care. When you're looking at future problems, you can also see something like this. This is a particular patient that I worked on with a prosthodontist, a friend of mine in Europe, Dr. Mitroni, Francesco, and we saw this patient together at the before stage. So the patient had 4 implants placed for 4 anterior missing teeth, but as you can see, they are so closely placed together. The proximity is impeaching again on health. They also placed at different vertical positions. Some are deep, some a little bit more shallow. They also have no keratinized gingiva, and they also have limited amount of buccal bone because they were pushed too far buccal. So overall, patient is having pain. Overall, patient is very unhappy with this non-existing gingiva, and we're dealing here with a situation we cannot solve. So we have to start over again. And these are a lot of the repairs that I do in my practice for soft tissue problem and bone problems that we basically have to remove implants. So in the middle photograph, you can see after we removed the implants, you see here like quite a severe atrophy of the crestal bone and of the horizontal bone. So this is obviously the starting point now for reconstruction. On the right side, I'm just showing you the end result. That's about 1.5 years plus work that we did surgically and aesthetically for the patient. And the end result you can see here, actually beautiful mucogingival line. It's all keratinized gingiva. And you see actually a 4-unit bridge with 2 pontics in the middle in this particular patient. So it's a 4-unit bridge on 2 implants in the lateral incisor, screw retained. And look at the change in smile, and look at how this all went from artificial to biological. A similar type of condition was seen here. You can see that in this patient here. This was like a patient who had 1 central incisor lost due to trauma. Rest of the teeth were all natural, good, just very thin soft tissue. But the lateral incisor had also some loss of bony peak on the mesial, so that's where the papilla is. There was a root canal, which was incomplete, and there was an apical radiolucency, which was seen here. And on the cone beam CT scan, the lateral incisor showed no bone. So that tells me, in my diagnostic planning, that for me to restore this patient to a level like you see on the right-hand side, I cannot do that with a compromised tooth like this. So I have to first remove the lateral incisor. Like in the previous case, I removed implants to get to a clean surface. Here I'm removing a natural tooth. You can see it in the middle photograph. And you can see already like a little bit the dip in the vertical, especially in the horizontal. And also you can see the dip in the mucogingival line with 2 frenulums coming in. So this patient then was restored again. It took about 1.5 years with bone GBR, with soft tissue mucogingival procedures, and with a facial gingival strip graft to finish the mucogingival line once the restorations were delivered, the final ones. Now look at the scallop the patient has. It's like nicely rotating around the central incisor and around the lateral incisor. It's nicely filling the spaces between the central and the lateral, so that's really good. It's nicely filling between the lateral and the canine, which is a natural because there's a full bony peak on the mesial of the canine. And it's also filling the space between the 2 central incisor because, again, you have good periodontal health on the natural tooth. So overall seen, this comes to a very nice, potential end result. So what do we base all this on? I think it's really important when you're thinking about bony regeneration and mucogingival structures that you have to always think about biological width. So you have to think, how much soft tissue will I get around an implant on top of bone? But the truth is, you can also say, how much soft tissue I'm going to get around a natural tooth? Because they're somewhat similar. I mean, they're very different structures. So when you think about collagen fibers, when you think about vascularity, when you think about attachment, very different. But the thickness itself is somewhat similar. So we say today that the biological thickness of soft tissue, so that goes in an apical coronal direction, from the bone to the gingival crest, it's approximately 3 millimeters. And we base that on studies somewhere in the let's say 1990s to 2000. So around that 2000 year, a few years before, a few years after, that's when we established this. And I have a paper which I wrote in clinical journals just about that time, 97, 99, where I came to the conclusion that for you to get a stable gingival margin, you need to place the neck of an implant approximately 3 millimeters below the gingival margin, the facial gingival margin, so the buccal gingival margin that you want to achieve in the patient. If you have too much bone in the crest, you still keep the 3 millimeter rule, but you go a little bit subcrestal. If you have more than 3 millimeters, then you have to go a little bit supracrestal, and then you just have to do a GBR to increase the bone width and the bone height. So that's really important. So this is the biological width height of soft tissue, which goes straight into bone. Because if you don't have soft tissue thickness, bone is going to resorb. If you have soft tissue thickness, it will preserve bone. That's as simple as it is. So you have to think about that when you're looking. And here's just like a diagram of an implant with an zirconia abutment here and a natural tooth, as you can see. And basically what it says, the biological width or height around natural teeth, from the crestal bone to where the gingival crest is, same the biological width around the implants, from where the bone level implant is with the bone crest to the gingival crest, about 3 millimeters. So we're doing this here in our planning for aesthetic restoration. So biological dimension is 3 millimeters. And of course you have to be realistic, because what you're dealing with is that an implant has different structures, as I said. You have epithelium, you have collagen fibers or connective tissue, and you have, of course, also periostea. But together, it becomes a biological dimension, which is all about 3 millimeters, and it compares to like these old periodontal studies, which I have mentioned here in a reference point here on the top right, 1961. That was before I was born, and probably most of you were before I was born, so that's a long time ago. But that's as long as we go back in biological dimensions. That was, of course, around natural teeth, but implants seem to have something similar. So here's a beautiful study which came out later on. That's that time when I came up with this clinical height and stability. You can see that soft tissue dimension around implants means, again, on top of bone, is approximately 3 millimeters. And it's the same for a bone level implant, for a one-piece implant, and for an implant with a platform switch abutment, which we don't change anymore. So whatever the bone crest is, wherever you're going to regenerate the bone with GBR, on top of that, if that bone is stable, you're going to get approximately 3 millimeters. So that's why this is such an important concept when you're doing especially aesthetic implant placement. You got to remember, what is my goal? So what's my aesthetic goal with the gingiva? What's my aesthetic goal with the mucogingival line? It's the goal which is important. It's not the present, because the present, the gingival margin might be like, all the way apical, because there was resorption. It's the goal which is what we need, right? And then from there you go back and you say, okay, from that goal of gingival crest, I need to subtract 3 millimeters, because that's my soft tissue dimension. And that's where the bone needs to be, and that's where I need to place the implant of a bone level implant. And then I come again in the question, do I have enough bone there? If the answer is yes, great. It's a great dance in happiness. If there's not enough bone, you got to regenerate it. And that's why GBR has become today, at least in my practice, since the beginning of my experience, which is like 1990 plus or minus, GBR has been part of my daily routine to increase that thickness and to increase the height for us to achieve success with implants. So it becomes like really a crucial part. To showcase that more, I go back to that one case I demonstrated to you earlier. So we have already determined that these implants are not good. We have already determined that these implants need to come out. I use usually a simple tool, which is called an implant retrieval tool, to remove them. And then, of course, we go at and we work with regeneration. And I'll show you that in a moment. And so we can get to an aesthetic result like you see on the right side. Now, how much bone do you need? Now, look at this one. This is a beautiful reformatted analysis of that anterior ridge. And what you can see here in this particular anterior ridge is on the left side, so the yellow-greenish, the lime color, is the jawbone. On the bottom, the teeth here, they're more green. That's the lateral incisor, and that's the central incisor. And you can see whatever is here in the red between the green and the lime color, that's bone which is missing. So if I would move my implant into that position and sink it all the way down where the bone is, which I could, I mean, I have no gingiva. So I have to work with pink ceramics, which of course is an option, depending on many factors. But if I follow with guided bone regeneration, look what happens. From the left photograph to the right photograph, we just change the colors. So now the jawbone has become normal gray color. The teeth are still green. You can see how I was able to achieve in about 9 months' time, using an autogenous xenograft mix with a non-resorbable titanium reinforced PTFE membrane, I was able to achieve a beautiful buccal bone balcony and a beautiful vertical bone height around these future implant sites. And now, because the relationship between the new bone and the teeth is like, in the right relationship, now I can place implants pretty easy as long as the bone is mature and thick enough. So that really works well. Now, this vertical type of regeneration for patients is really important to know, and we need to evaluate that, and you can see that here. So what I do, and that's usually done in collaboration with really a great prosthetic colleague or a great aesthetic colleague who knows how to manipulate the software planning. So I can give him or her my CBCT, which shows me the bone, which you see here. And then the colleague can actually put in here the missing dimensions of of soft tissue. Because the dotted line here is actually the dotted line of the future gingiva. So again, it's the goal that we have to have. The goal is not to go down to the bone. The goal is to have this gingival margin. And so I just need to subtract about 3 millimeters from this goal to know where my bone is supposed to be. So that's my vertical reference that I need to always establish when I'm thinking about an ideal implant position. And, when you have enough bone, and I'll show you just here, an upper and a lower jaw. So when the bone volume has more height than 10 millimeters and the bone width is more than 6 to 8 millimeters, of course, you're not fighting. This is pretty straightforward work. It's, I wouldn't call it simple, but it's pretty straightforward. So this is not the problem. The problem is when you have less than 10 millimeters bone height. The problem is when you have less than 6 millimeters bone width. That's where the soft tissue and the mucogingival condition becomes unstable. So that's why we have created this vertical reference point. And you can see here 2 different cases. On the left side, I'm doing a staged bone augmentation. on the right side, the right two photographs, I'm putting already implants in and putting them at the right vertical height, so about 3 millimeters is below the ideal gingival margin, and it exposes now about 2 to 3 millimeters of implants. So on the left side, I have to use some kind of support mechanism like a 10 screw to give me a reference point, how much bone do I need. And the membrane itself is the same, it's the titanium reinforced cytoplast. And then on the right photograph, you can see that I used actually a healing abutment to get to that right vertical height. Both outcomes, so left and right, this is the staged one with the 10 screw, this is the healing abutments. Both of these are showcasing full regeneration after about 9+ months. And that's what we're talking about when you're trying to do the ideal restoration with a goal that the gingival framework is in the right position. So that's really like, where we're going for. And you can see that I published this here in 1997, 1999, and the title that I gave that article at that time was Bone Rehabilitation to Achieve Optimal Implant Aesthetics. And it all had to do with just knowing what the goal will be, placing the implant 3 millimeters below the goal, and regenerating the missing bone, and then producing thick soft tissue. So that's the way we work with these patients, now and in the future. So it's really, really important for us to see this. And this kind of regeneration becomes really crucial. And as you can see, look, I can place here a gingival margin, and that's where the reconstruction is already done. And then when I open the flap, I can see all this new bone. That's the case with the staged approach. The 10 screws right there in the middle. So now I can go in and can say, okay, where do I need to place the implants? Am I going to go for 4 teeth with 2 implants? I'm going to go for 4 teeth with 4 implants. I'm going to go for 4 teeth with 3 implants. And then you can just make a clinical assessment, the bite of the patient, the age of the patient, the diameter of the implants, the disclusion on the canines, all the things that could have to do with factors of bite. And then also you're going to have to look at how much bone in mesiodistal dimension do I have that I can place 2 implants or 3 or 4. Because in between each implant proximity, of course, you need, again, bone to survive. So that's like, a good number of millimeters. So here I decided, because of the limited mesiodistal space, and also because I know that Pontics can be recreated really beautifully, I developed here a diagnostic plan to place 2 narrow platform implants. So these are 3.5 millimeters conical connection in the lateral incisor. And I used here guided surgery, just so I have them really in the ideal position. Because do remember that placing implants into the lateral incisor position, you have no room for error. You have no room for error because the tooth is too small. And it's always has a little effect on the implant restoration when it's a bit too mesial, a little bit too distal, a little bit too palatal, a little bit too lingual. So it's the one location that you're looking for. So, and the guided surgery can really help you with that in a patient like this. So this is really important. Now, I also want to just kind of be fair, and that is to say, not every case can have the ideal soft tissue. Not every case can have the ideal bone regeneration. So sometimes pink porcelain is better. Think about elderly patient. Think about patients who have some kind of compromised condition. We're talking about health condition. So, that can be achieved with pink porcelain, but, just you got to remember again, on the smile line of the patient, on the low, the transition line, can you hide this behind the transition line? Nowadays, I'm just going to make a reference to our life today. It's maybe less important because we're all wearing a face mask, at least here in California, so people don't see it. But once we go back to a new normal, the transition line is going to be essential. So, but my lecture is not so much about pink porcelain. My lecture is more about mucogingival line and how we are creating this type of evaluation. Now, let's move a little bit to soft tissue. It's very important for me when I look at patients to understand that like an implant needs bone. And I've developed that hopefully with your understanding and your agreement. Now, of course, I have to go into soft tissue, the mucogingival line, because look, there's no implant site which can have good long-term longevity, securely and scientifically speaking, to a high percentage if you have thin tissue. So this study I just use as a reference, and I give this to my patients. You can say that soft tissue and soft tissue grafting is very important because it will result in more favorable or in better peri-implant health. So keratinized mucosa, taking it from the palate, will have a higher marginal bone level, so it's better. If you gain mucosal thickness, again with palatal grafts, you have less marginal bone loss. So when you are proposing to your patient after you've diagnosed, because first the doctor has to diagnose this. Many clinicians don't diagnose this. But once you diagnose that you're missing keratinized gingiva, and once you diagnose that the tissue is too thin, you can propose these procedures to your patients, and you can say, look, we're doing this so the bone is more protected, the implant is more protected, and you show less bone loss, so there's less risk, for example, for peri-implantitis. So this becomes really important for patients to know this. And I'm always happy to give a scientific paper to patients because, it's then they don't have to be Dr. Google and try to figure it out on themselves with sometimes some, not very scientific information that they could get confused with. So give them something that you feel comfortable with. Another part of diagnostic, which is really important, I need to give myself, the aesthetic dentist, the patient, the technician, a guideline. So a surgical stent, which is created with the goal of us in the future, is really essential. I don't need to see the pink acrylic here. I just want to see what you see on the right-hand side is what's the sharp gingival margin of the future. Because I want to graft towards this bone and soft tissue. Okay, so that's really important for me. So that's the part which is really good for us when we're doing this. And you can see then how I can use this in the patient, to bring the bone to the right level, bring in the implants in the right position, and if I need to maybe graft extra, I can do that. Or if I need to move in and add some soft tissue thickness. And then that's my goal. Look, 2 implants in the central incisor with a nice circumference here, nice gingival papilla, and patients are usually very happy with this. You can do the same thing with the digital. So this patient was recreated and software planned with digital. So, and then we went to the prosthesis. You can see a patient who had no teeth in the upper jaw, but we reconstructed it. We placed the bone at the right level. And then as you can see here, we have teeth. This is still the acrylic temporary face, but you have here the circumference that you want. So vertical bone regeneration on that bottom left using a titanium reinforced PTFE membrane was crucial to get to this success. And here you can see that. Here's the titanium reinforcement. Important to say this is a non-perforated one because there's also some perforated ones today available in the cytoplast family. So this is really crucial. Now, how long can this last? You can see this here. Look at this case. I did this one with a colleague in Europe, Dr. Mauro Frediani. And tell me how difficult it is in your mind to recreate soft tissue between a center and a lateral. And we probably all will agree on that it's not easy. So we don't never want to like over promise to patients. But here you can see that, look, we were able to do this like almost 20 plus years ago by just following the biological principle, following GBR, augmentation procedures, following soft tissue thickening procedures, and following good prosthetic principles with a final abutment. At that time was alumina, zirconia didn't exist yet, and then look at the gingival margin. So beautiful case, and if you ever want to study prosthodontics, you can read Dr. Frediani's book, textbook on prosthodontics, and you'll see this case well outlined in there because we were both very proud of the achievement that we did for this particular patient. So questions which sometimes come up. Abutment material. Because remember, you have the bone and you have the soft tissue. But in between those two, when you're using a bone level implant, you got to bring in some kind of biomaterial, which is an abutment. So the answer is pretty easy. Plastic abutments are out because they don't fit. Tissue doesn't know what to do with it. Not really highly biocompatible. So it produces inflammation. PEEK abutments, also not really great because we don't have a lot of scientific evidence on that. So basically what we're saying today is use titanium, like we've done for many years, and use zirconia, which we've used over the last 10 plus years to preserve soft tissue and to maintain thickness. So those are the two materials I use. So usually posterior I use titanium, anterior I use zirconia. If you just want to have a generic way of, how do I differentiate between these two? And that really helps me. Abutment dimensions, really important, because look at this single tooth case that I did after GBR and before creating the soft tissue. You can see that with my colleague, Dr. Kyle Stanley, we did this abutment, and it's good. It's placed in one time, but look at the kind of widening of this here, which was given to us by the technician. We didn't like this because it puts too much lateral pressure on it. And we have some papers now who are saying when you go out over 40 degrees or so, this can again produce bone loss and possibly can create periimplantitis. So we gave the abutment after the x-ray back to the technician and asked him kindly if he could give us a more slimmer abutment rising out of the implant and rising out of the bone. And slimmer means basically the width of the implant. And then once we pass that bone and first connective tissue layer, that's where we can widen out to get to a form and shape of the final crown that we're going to be proposing for this patient. So this is really important. Timing also very important, something that is relatively new, not super new, but this paper came out in 2016, so it's like 4 or 5 years old now. And basically we are saying that healing abutments are out. Short titanium abutments are in. Final abutments are in. You basically don't want to put something into the implant anymore that you have to remove to take impressions and then have trouble with the bony periosteal layer. So a one-time abutment placement is really important. And you can see here, this came out of Spain from the Sanz family. And the conclusions were pretty easy. When you're connecting and disconnecting healing abutments, you're going to have some bone loss. So try to place an abutment one time and leave it there. That's really crucial for you. And then all this together, the soft tissue thickness, augmentation, the bone, a good abutment material, a good abutment positioning, that can help us. So when we do temporaries today, we go in and we've taken already an impression of the implant. We have already recreated the bone, as you can see in this photograph. We now have taken a bone level impression. So while the implants are healing with osseointegration, while the bone is maturing and everything is submerged, no disturbance with the overall healing, I'm making with my technician a final abutment. Here I made 2 zirconia abutments. And I'm making final form and shape that I think of these 2 anterior teeth. I'm placing all this at uncovering, and then if I want to enhance the thickness, I do a connective tissue graft. And you can see that here. A connective tissue graft was placed here and really, really nicely accentuating how the thickness is. So that looks really good. And now we're placing the soft tissue flap around it. We're suturing that. Here I'm using monofilament nylon sutures to give some coronary positioning. And you can see that I actually am now creating thickness, shape, and bone is protected, and almost too much soft tissue. So now that's great, because for me to cut back some gingiva, of course without jeopardizing keratinized gingiva and the mucogingival line, it's easy. It's like a sculptor who has a nice amount of stone to work with, and now we're just cutting it back, chipping it back, so we get to the same height as we really want. Not like a sculptor or a painter who is trying to add materials to it, which is, maybe when you're a sculptor it's easier to do because you can just add, but when you're a biologist who has to work with surgery, it's not easy to do. So the old school type of in and outs of temporaries and adding composites and adding acrylic is not really something we do anymore. So that's really important for you to know this and really try to emphasize this. Now, soft tissue grafts, where do we get it from? One of my favorite sources is this type of gingival grafting which we have developed at the university here in Los Angeles. This was still the time when I was full-time active at UCLA. And 2 of my colleagues particularly got the credit, Dr. Henry Takei and Dr. Han, for developing this, I would say, really smart and efficient and creative way of using palatal grafts. And they called it the strip graft. And I totally agree with it. And you can see still today, a lot of the periodontal world is using this here. And you can use this as an epithelialized strip graft, or you can remove the epithelium and it can become connective tissue only. The only downside of this particular strip graft is that it's very dense, so the connective tissue is quite rigid, so you cannot nicely shape it around the ridge. It's really more for a uniform type of situation where it's really, really nice in shaping it in such a way that it kind of lays on the buccal side. This, for example, here you can see that that's a connective tissue graft, which I'm just laying on the facial in between the abutments. Now, palatally though, these thin grafts, they heal beautiful. Look, 2 weeks after, you almost don't see it anymore. So it's really nice. 4 weeks after, it's completely healed. So we don't even need to suture them. They're so attractive and so friendly in their healing. So that's really beautiful. And here you can see a larger one. Look, there's a really long one. A really it goes from premolars all the way to molars. This one I did still with some sutures, but it's really not necessary. The only thing that we try to do is put these plates on it so that there's some compression on the wounds, and we have a nice way of maintaining here the overall the blood coagulum. So this becomes really important for patients when they do this. And to show you here a little bit how this looks, this is the patient you saw earlier. So here at uncovering, I'm placing short titanium abutments. They're about 1.5, 1.75 millimeters in height. I have opened up the site just with mini flaps. So these are mini mucogingival flaps. I pushed somewhat of the keratinized gingiva to the buccal, and I placed these short abutments. Then I have the temporary ready. They'll be made by the aesthetic dentist. The temporary was made already to the specifications of the aesthetic case by the technician, under, of course, the guidance of the prosthodontist or aesthetic dentist. And now I just have to fuse them, right? I have to fuse them with the abutment. So this is a minor modification that I'm doing here, and it's screw retained. So it's placed, done. This is at uncovering. So I have a four units with two Pontics that are placed here. But what's important here, when you look at it, look at where my mucogingival line is. You can see I've created a little bit of keratinized gingiva around the implants. I have no keratinized gingiva around the Pontics. So when the patient has a full smile line, it's not going to be very aesthetic. And also maybe not that stable over time. But I have already my thinking cap on, and I say, how am I going to change this? Well, I'm going to do a mucogingival procedure. The mucogingival procedure is going to go follow the line. I'm not going down to bone. My bone was GBR, remember. I worked hard for this here to get it in the right vertical position. Because remember how this case had this severe vertical and horizontal atrophy. So I want to create a recipient site, which I go down to collagen, which is attached to a periosteum. So it's an immobilized periosteum. Then I take that, I transform it to the palate, and I'm going to take a strip graft. The strip graft is going to be nice because it's going to be either like a slightly customized, like in this one, or it could just be like a rectangular shape. And then I'm going to place that on top of it with sutures, which can be either resorbable sutures, because it's like a little bit of a deeper graft placement, or it could be like small nylon sutures. And they're going to be stabilizing this here and really gently pressing the gingival graft to the underlying periosteum and connective tissue, so we got optimal healing potential. And here you can see that. So this case beautifully done with my colleague Francesco Mitroni, and you can see how the graft was placed around the implants, around the Pontics. It's sutured here with nylon, and actually I use here also Cytoplast PTFE. And you can see how the Pontics are absolutely now supported with keratinized thick soft tissue. And because there's such a nice dense adaptation, look at how this heals. 2 weeks later, you have here a graft which took pretty much, the way we would like it to be. So it's like as good as it gets. And then when you look at the temporary, look, this is the change. Left side, this was before the patient was treated. So this was day of intake or day of consultation when all the complaints came in. Right side, you can see, look, that looks good. It's the keratinization. So the only thing I need to do now is wait for some maturation. Usually I wait 2 to 4 months. And then we switch this bridge from a temporary PMMA bridge or temporary composite bridge into a final bridge. So that's like, as beautiful as we're going to maintain this here. So that's the strip graft that we're using for these kind of patients. So it's quite beautiful and quite successful. Now, there's of course other type of soft tissue and bone enhancement materials that we use. You can think about Emdogain and collagen, natural periodontal growth factor. You can think about PRP, platelet-rich plasma, for bone enhancement and for wound healing enhancement. But, having seen and worked with many of these growth factors over many years, it's really not become an absolute replacement therapy. So GBR with using autogenous bone and membranes, and soft tissue grafts from the palate to thicken soft tissue and to increase keratinized gingiva is still the norm today. So that for me is a norm that I cannot replace. So this is really for me the main thing. And this is quite a nice paper which came out about 5 years ago from the American Academy of Periodontology from one of their workshops. And it included quite a beautiful panel which has a lot of experience. And they basically came out with the conclusion that really nothing replaces the biological natural materials like we have from our patients. And the rest is possible. It will add to a possible wound healing. It will add maybe to some bone healing, but it's not a substitute. So for all my challenging cases, I'm still very much a big proponent of autogenous bone harvesting and grafting, membranes, to protect the bone and regenerate the bone, and palatal soft tissue, either from the palate or from the tuberosity, to really create this type of healing. So use that kind really as an essential part of your work. Now, sometimes people ask me, well, how do you create this synergy between bone and soft tissue? And how do you create actually these abutments so you don't jeopardize the GBR? Well, as I said earlier, I transfer the implant position after the implant placement right away. So once I place the implant, my goal is to transfer or use an impression coping. Of course, there has to be a new one, a sterile one. Place it into the bone, place it into the implant, and then I take an acrylic pickup like you see here. I take a normal impression with normal analog material, or I use a digital. 3 options. This then gets stored while the patient is healing with its bone graft and with its soft tissue flap. And then once this is finished, so once the bone healing is finished, I've already asked the technician to make me an abutment, and that abutment is ready to go. Because I know where the soft tissue will be. Because remember, I was planning this smartly. I was planning where is the soft tissue going to go. And that's going to help me. And then the temporary, of course, is going to be temporary material. But the abutment, the goal is to leave it in place. So this was a zirconia abutment that I used for this particular patient. And then look what happens in the healing. You can see that here. Soft tissue healing. The way it had the synergy between bone and soft tissue. Good keratinized gingiva on the buccal. Good thickness. Screw retained abutment. A nice margin there. You can see that in the zirconia for the temporary and then later on for the final. And then when I place the final, I actually even allowed this to be screw retained because we opened the crown in the cingulum area. So after cementation, some of the cement can come out. And also afterwards, if I want to, I can always put my screwdriver through it and remove the one piece now of the zirconia with the crown. And that's the way it looks in its healing, really, really stable. So now look at the before and the after on this patient. The 2 photographs on the left show you the before. So you can see absolutely no mucogingival line. Thin soft tissue. No buccal bone. Even lost interproximal bone. Now you go to the 2 right side. How about that? Bone up to the level of the implant. Using GBR. You can still see the pins that I left in place between the roots. And you can see a zirconia abutment, nicely created, that was placed at the time of uncovering. Look, no bone loss, 0% bone loss. And then look at the gingival framework. It's more coronal than it used to be, so the before, and it's more coronal than the adjacent teeth. And the interproximal papilla filled. That also had to do, of course, because the periodontium on the two adjacent teeth had good bone on both sides, here and here. So that looks really good. So, this is good stuff. This is good stuff, and patients, of course, love this when we can do this for them, because it creates such a balance for them from hard work and from aesthetic work and how this is done. Now, many times doctors say that like two implants next to each other are impossible to do aesthetically. And I do not agree with that. I would change the word impossible to challenging. And that it takes a lot of time and effort, a lot of planning. Because remember that these are two 3.5 millimeter implants that we're replacing for the central and for the lateral, missing, with vertical bone loss, with horizontal bone loss. So these patients do actually have a criteria which is not easy to fulfill. But if you can get, about 3 to 4 millimeters of bone between the two implants, and you can get about 2 millimeters of bone between the implant and the natural root, and you calculate that all together, that's all you need in spacing. Then, of course, you need to be very precise in placing an implant. And then you need to make sure that you have the bone there, and then you need to make sure that you have the soft tissue mucogingival line there. But look at what's happening here. That's a case which is also approaching 8+ years now in restoration in the front. Look, patient got also some ceramic on natural teeth, but soft tissue-wise, bone-wise, no bone loss, final zirconia abutments, one time placed, and then 2 crowns on the lateral and the incisor again with full papilla. So I can't complain with this, and this is, if I can get a patient like this who actually traveled from far distance and give him this result, I'll sign on for this right away. So is this impossible? No, because this is one of our cases. Is this challenging? Absolutely. So you have to kind of that's where that list of goal comes in, which I presented to you in the beginning. Try really to be very, very precise so you don't make a mistake and you don't allow yourself to possibly get into a problem. Now, when we're talking about soft tissue and when we're talking about bone, I'm going to give you 2 different lists, right? First of all, I'm going to give you here the list of soft tissue, because to do periodontal mucogingival procedures around implants, you got to have good instruments. So I mean, it's like really essential. I have an instrument list from Ufridi. It has worked for me for a long time, 20+ years, and we do all these different procedures which you see on the left side, from gingival grafting with epithelium, without epithelium, subepithelial grafts. We take split thickness flap, full thickness flap. We move them coronal, apical. All this you need specific procedures for and specific tools. So do remember that you need to create a certain amount of materials to get to this end result. So I want to show you the same thing on the clinical side. So when we're looking at the clinical side, you can see here for GBR, I'm giving you here the example of the patient you just saw. Then you need to know how much bone you need to create, right? So here is the software planning. I'm creating here about 7 to 8, 9 millimeters of vertical bone, and I'm creating about 8+ millimeters of horizontal width. I need GBR for that. Before I get to the soft tissue, I need GBR. So that's what you see here. And here's my little cookbook, if you want to call it like this. And in the pandemic, maybe some of you have learned how to be better at home and not to rely so much on always going out for dinner. But these are all the tools that I'm using, and I'll go through them so you understand all the different parts and pieces that I'm using. So you can see here, the titanium reinforced material is right here, cytoplast. That's a really, really important one for me because I can create here stability. I can create here non-resorbable protection of that bone graft, of course closed with this flap primarily. And I can leave it here for 9 months, for 1 year. The bone will get better. It's going to get more mature. To stabilize that membrane, I use either screws. This is the Profix system from Osteogenics, or I can use a pin set. That's fine too. Either one of them, whatever, is they're both efficient. It's just one is a screw, the other one is a tack. Then I often use as a second material around the cytoplast, especially in the borders where sometimes some bone is kind of wanting to migrate out, a resorbable membrane. So I make this hybrid type of GBR procedure. One is the non-resorbable material to protect the bone completely. The second one is the resorbable membrane just to keep the bone in place in the periphery. Then how do I get bone harvested? So these are my favorite materials. This is Micros. It's from the Italian company Meta. And those scrapers are really efficient. I mean, they're like really good. They came out recently with a Micros Curve. Also very efficient because it has like a little curvature to it, so it's easier to scrape. But it has the same efficiency like the Micros, so just curved a little bit. And that gives me my particulated autogenous bone. Then I use a xenograft. The xenograft, it's a particulated xenograft. Here it's the BioOS type that I use, and I mix that with the autogenous bone. And then again, for closure, I use here cytoplast, PTFE suture. It's really a beautiful monofilament suture, so I can create primary closure in a patient like this. Then I always, and this is really also important for you to know, we always ask the patient, and we always have the patient in mind, is after all this hard work that we do, and after also all the, invasion that you do on the patient, and the trauma, and the discomfort, and the pain for the patient, the downtime for the patient, what's the temporary going to be? Don't let the patient be surprised, with words, well, I can't place anything now, and patients go home without anything. So you got to already create for them like a visual that they can really understand what it is, before they go home to get to that end result. And the end result, the patient, once they get to the end result, my God, it's so beautiful because look, I can give the patient now, that's the temporary with the 2 implants and the mucogingival line. Now that's already fixed, right? So that's a fixed temporary. Now I just need to create the final, and here's the final. That's great. But there's a journey, about 1.5 years, could be longer, up to 2 years, that the patient goes through multiple procedures of bone and soft tissue and implants, and you got to give them something. So it could be if necessary, removable, as long as it doesn't press in that area. Better to be tooth-borne or bonded so the patient has something which is really stable. And look at this. This is the before and the after. So on the left side, you can see how much bone the patient was missing vertically and how much bone the patient was missing horizontally. And on the right photograph, you can see after the teeth have been restored aesthetically. Look at that beautiful ceramic. Look at that contour done by the ceramist, controlled by the aesthetic dentist. And then look at the gingival margin that I got here. And I'm just thrilled how I was able in this particular patient even to get some stippling into it. So it looks like almost natural, patient's own tissue. And look at this one. the before and the after. On the front, it looks a little bit more pale. So that looks more artificial gingiva, or like, let's say, grafted gingiva, but it also still looks really amazing. And then here's the support of the facial lip and the support of the gingiva, and how these pontics are actually emerging out of the gum. So this is really as good as I can make it happen in a patient like this. So really, really successful in a patient. The transfer of bone and the transfer of soft tissue, and to make it really clean and beautiful. I showed you before another case, which is also the same for aesthetics from a soft tissue standpoint and bone standpoint. So here's the series. Notice here the atrophy on the patient in the central incisor, the compromised lateral incisor with no periodontium, the incomplete root canal, and the missing bone. So we're removing first the tooth, and we're doing this delayed extraction socket, which I published with Dr. Danny Boozer from the University of Bern. And Danny has been instrumental in the implant field with a lot of scientific contribution, and also, like, I would say, one of my best and favorite GBR contributors, besides Massimo Simeon, because there was so much good work coming out of Bern to learn about GBR. And we're actually publishing this year a book under the authorship of Daniel Boozer on 30 years of journey on GBR, and it's going to be published by our global publisher Quintessence. So be on the lookout in the fall. It looks like that it will be released. And this particular case will be in the book. So you can see the removal. This was a publication that I did with Daniel Boozer. It's called Delayed Extraction Site Protocol. And then we go, from having one tooth in there, which we can't really restore well, to two teeth missing, but then look at what we're able to do after a year and a half. So this is the bone that the patient has currently. So there's a very diminished buccal bone and diminished vertical bone, only 2 millimeters. And then we're grafting this here in a vertical sense. Look at the amount of graft we're placing. So that's really important for you to see how much bone you need in a site like this, so horizontally and vertically. The titanium reinforcement already in place, palatally secured. And then look at the regeneration. That's 9 months later in a cone beam CT scan. This is positive bone. Look at the quality. Of course, this patient is younger. She's in her 20s. But it has regenerated all the way to the titanium strut. And then look at the width. There's definitely enough bone to place 2 beautiful implants. So that's the bone before and after. And that's the horizontal bone before and after. So very strong in its positive reaction after 9 months. But this was 9 months, uneventful, stable, titanium reinforced with a big particulated bone graft. And here's the bone vertically and horizontally, which gives you really a nice essence. So now I go into like what we call the smart fusion, right? So I want teeth. They were actually done by Dr. Kyle Stanley, this analysis. He's one of our prosthetic partners here in Los Angeles. And you can see how we're moving and creating the final teeth, so we can see how is that relationship with the bone. And the beauty here actually is that there is a beautiful relationship. So you see the teeth, how they're emerging out of the gum. So it's already, the bone and the soft tissue is already there. And then we're doing in the software planning, here we're using in the software planning from Noble Biocare, and we're creating here the space for 2 implants. And you can see it's completely in the regenerated bone. I haven't opened the flap yet. I'm just recreating this here so I know where to go. And we're going to use guided surgery here. Again, because there's limited amount of space, for this particular patient. Here's the 2 implants placed guided, so not much room for error here. I do always make a second stent, so I'm very careful to do that. That's more like a laboratory fabricated one. The 2 implants were placed, and now comes something which is very interesting. Look how the positioning of these 2 implants is below the crest of bone. And I have to say something. They were placed below the crest of bone, not because I want to create more thickness of soft tissue. No, they're placed below the crest of bone because that's the 3 millimeter distance that I need to the future gingival margin, the goal. Remember the goal again. Now, I happen to have too much bone here, so I have the luxury to place them deeper. And what that will give me is bone in between the 2 implants, which is more coronal, which will support a soft tissue papilla easier. That's the idea. Now, then I take the impression. Remember, I place an implant, I take an impression. This was a traditional impression I made. New sterile impression copings. I suture the flap a little bit, close it a little bit, just for the taking of the impression, and then we remove everything. Then I go to placing, in this case, like short healing abutments, because the implants were subcrestal. And then you see here what I call an GBR and soft tissue contour graft, because I want to thicken the bone again. I want to thicken the soft tissue again. And I do that here with xenograft only. I don't need autogenous anymore because I have enough mineralized tissue here. I need a resorbable membrane to keep it all in place so it doesn't move. And on top of that, I need a soft tissue graft. And this is actually a subepithelial connective tissue graft, not a strip graft. So I can move it more into place. I can, like almost like a saddle, it can position itself on the membrane a little bit better. A strip graft would have been a little bit too dense and too rigid. So that's something that I wouldn't really like to do. Then I submerge everything again. And I notice here how the soft tissue flap is coronal to the adjacent teeth. So I have too much tissue there. But this is keratinized. Here's the mucogingival line already. So the mucogingival line is way too coronal. But I'll address that later. Here's my abutments. They're already made during the healing of the implants by my technician. And the margins are in there. The screw retention is in there. It came all from that guided implant placement. Then I come in a mini flap, mini openings over the implants, move some keratinized gingiva towards the buccal just to preserve that. And then I place the temporaries. Sometimes if I'm lucky and the impression that we took was really precise, it just goes in there like a glove. Another time we have to adjust it a little bit. So we're always ready with some adjustment burrs and drills and of course floss and contact point and occlusal paper to make sure that this fits. But if the impression was good, your abutment was made from the impression, the temporary should be good too. So now you can see that the only thing which is missing here is a correct mucogingival line and maybe a correct filling of the papilla. Otherwise, this is all done on the day of implant placement. So what do? I place as you saw, the final abutments. We're not going to change those again. I uncovered over the implants. I just need to recreate now the mucogingival line. And what do I do here? I go to the palate. Now I take my second soft tissue graft. Remember, I took the connective tissue graft a moment ago. And now I take a strip graft because I'm just going to lay it on the facial. And on the left photograph, you can see how I'm doing an apical reposition of the flap. And I suture this with a resorbable suture. And this is where I use the Resorba sutures, the monofilament glycolon sutures, which are suturing the margin of the mucosa towards the periosteum. And a little bit of keratinized gingiva I leave around the abutments. It was there. And then the strip graft, I'm doing something which is not always my goal, but in this case I did. I removed here the epithelium. And the reason I did that was just for color scheme, because otherwise the material can get so pale. So because the connective tissue is so dense. So I just removed some of the epithelium so it can grow in easier. The epithelium I trash. So I get rid of. And then you can see the suturing. If I want, I can put a little bit of collagen at the base so there's not such a big wound open. I maybe also don't need to do such a big apical repositioning of the flap, but that's all possible. And here you can see I used a little bit of a collagen at the base, collagen replacement material, just so that there is not too much trauma of an exposed wound. You can see that. I can suture that. And then this is the temporaries. So now the temporaries have the final abutment and the proper contour and extra soft tissue from the keratinization and extra soft tissue from the palate. All this will heal. And these are the implants. X-ray shows you the couple of millimeters of subcrestal implant placement, and especially you can see the extra bone which is in between the implants. Now look at this. That's the healing, the before and the after. So that's a continuation of soft tissue healing and guidance. So that's why I call this here. One is guided bone regeneration, to guide the bone exactly where you want to have it. And then this is guided soft tissue regeneration, but you're using the abutment and the temporaries to guide this all into place. And that's the beauty of patients like this. And here you can see the temporary in place. Notice how you can see very beautiful the healing of keratinized gingiva. You can see a little bit of color difference here. So I have a procedure which I call the plasty procedure. You can see that between the left and the right. The left was before plasty. The right is after plasty. And the right side, as you can see here, shows quite beautifully how I used a laser. I could use a laser. I have a water laser in my office, a BioLaser water laser, and I just do a little plasty. I can use a burr, round diamond burr, just kind of to scrape it a little bit. But the laser is really very, very efficient. I mean, that's because I have it in my office, I use that. And then we go to the result for this particular patient. Look at the before and the after. A nice scallop of this particular patient. Look at the gingiva. It's kind of disappearing a little bit. And here you can see the reconstruction of the anterior teeth. And you can see how, I mean, I'm not being very perfectionist-like and very, let's say, critical to myself. I like the central. It's good. The gingival symmetry I like a lot. I like the health a lot. I like the thickness a lot. The lateral incisor, as you can see, it's just off a little bit. It's just like it's almost like it was placed too far buccal and maybe a little bit too far mesial. But, I'm really being maybe very critical in a patient who, we did a very challenging case. And that's the 2-year follow-up. And you can see, and this is something that I also want to show you, is when you do these soft tissue grafts, especially from the palate, they keep growing. They keep thickening. And you can keep filling up an interproximal space. So make sure that you're not going to encroach too much on the patient's embrasure spaces. Because when you close the embrasure space, nothing can grow in. So what you can see here is actually that, here, in between the center and the lateral, it's growing nicely into this space here. And that's really what I like to see in a patient, that it's so nice and stable over time. So I'm quite happy to show you this. I'm quite happy to show you the result on this here and how this developed really for the patient's sake over time. And I have no doubt that, when you look at the particular healing that this patient has, that this will continue to be so positive over the period of time. So that takes us to the patient's time of work and the tool set that we have. So remember that with soft tissue, again, you're creating thickness. With soft tissue, you're creating keratinization. With bone augmentation, you're creating thickness in horizontal direction and in vertical direction. So that makes it really efficient from an overall standpoint of healing when you think about patients, how they heal with all this bone and all this soft tissue around it. And everything you do in your practice needs to really be focusing on this here. So create bone. From the bone, you're creating soft tissue, and then that will give you the longevity. So I will finish here with one patient, which is very dear to me because it's a 20+ year follow-up. And I don't have so many patients in America who come back to see me after 20+ years because they always move around and go to other doctors' offices. But he had a patient who was actually came back to Los Angeles on a regular basis, although she also lived in different parts of the country. So she had an anterior loss of bone, as you can see, very traumatic. And at that time, we were still doing some distraction osteogenesis, although we quickly switched her to, again, non-resorbable PTFE GBR. What I'm showing you here on the middle and right photograph is actually already the full reconstruction of bone. And you can see how the vertical soft tissue is in the right position and the horizontal soft tissue is in the right position. So now I have to open this up, uncover. I had 4 implants already placed. I have to place again the final abutments and the temporaries and soft tissue. So that's what you see here. 4 titanium abutments were used at that time, and 2 3-unit temporaries, so making a total of 6 units. I did again something that you've seen before now, an apical reposition, partial thickness flap to gain keratinized gingiva. All that tissue that you're seeing here is attached collagen, connective tissue with periosteum. So that's my recipient site. Then I go to the palate and I'm removing here one of the largest connective tissue grafts I've ever removed. So this is, I call this the mother of all connective tissue grafts. And I take this little mother and I place it on the facial. Again, these were the first moments that we were coming up with these ideas of creating thickness and guiding the soft tissue in the right position. This is all done around a temporary after, like a really significant vertical GBR and 4 implants. You can see the healing. The palate is really within 2 weeks is completely closed. The buccal, it's healing normal. It's not even epithelium on there. It's just connective tissue. And then we go towards the healing. That's about 6 months. On the x-rays, you can see how the vertical GBR is holding up with its mixture of autogenous and xenograft. In the middle photograph, you see the clinical establishment of the gingival symmetry, and you see the establishment of a mucogingival line. This is the bridge, or 2 bridges that were made by the prosthodontist. At that time, I was working full-time at UCLA, so that was with my partner at that time at UCLA, Dr. Ed McLaren. And you can see nicely here the amount of keratinized gingiva, which was created here. A little bit folding, but if you look around the teeth, you can see even the papillas coming through. This is 1 year later. right? 1 year after prosthesis. Now comes the shocker. 20 years later, same bridge, same keratinized gingiva, and look at the stability. And look at the thickness. So this patient wanted to grow with the soft tissue more, but we kind of had locked it into place because the embrasure spaces which we had created at this time. We didn't know that soft tissue is going to grow that much, but it was because the implants were in the right biological position and the GBR was so strong for this patient that it's supporting all this soft tissue. So 20 years later, you see stability, you see keratinization, you still see a beautiful bridge. Patient had no chipping. The ceramics and the zirconia were done beautiful by Dr. McLaren, and you can see the stability. X-ray wise, interesting. She got a little bit of, let's say, remodeling at the top of the crest, but it also maybe had to do with these implants. Types, they were the older external machine surface implants. No peri-implantitis, super healthy, and stability. So really a beautiful 1 to 20 year follow-up on this particular patient. So with this last type of long-term viewpoint, which hopefully will help you to understand the things that we're trying to recreate for patients, I can stop here. I hope that you enjoyed the lecture. Dr. Mike Urso, thank you for the invitation. Thank you for the support. Ken Beecham, thank you for the support from NYU. I look forward to do more work with you together and with your global network of dentists. This was my presentation on mucogingival and GBR procedures. I hope that you've learned how aesthetics is possible. It's challenging, but longevity for sure is possible. And for any type of collaboration, just come and find us online because we have a lot of amazing online educational programs at guidedental.com. And if you have any questions, please go ahead and through Dr. Urso, we'll go and answer them as good as I can.
Dr. Jovanovic, thank you so much for a fantastic presentation. We really appreciate you taking the time with our 11th Annual Global Symposium. Question number one that came in says, what is your opinion on flapless, fully guided implant placement? Is it better for soft tissue health?
Okay, first question dives right into like the meat of the topic, and also into the meat of like what we do like every day in incisions and implant placement. So if you think about flapless and you just think about generic areas like posterior mandible, posterior maxilla, you're thinking about edentulous ridges. You first have to say, of course, that you cannot 100% diagnose a ridge which might be too narrow or approaching what we would consider clinically to be too narrow, which would be somewhere in the range of 6 to 8 millimeters. So that's number one. If you do have the luxury to have a ridge which is definitely confirmed by cone beam CT scan to be more than 8 millimeters, then maybe a fully guided flapless procedure is possible and is safe to do. So that's for me the biggest distinction about the 8 millimeters width in the correct prosthetic position. But there is like a soft tissue element to it, which I think is overseen and you don't see that very often discussed. And that is that the soft tissue which you see on a ridge, often after a tooth is lost or partial edentulism, has migrated towards the lingual or to the palatal. Implants, of course, because they're usually placed straight up and down in the long axis of a previous tooth, are placed a little bit more buccal to where that mucogingival line is on top of bone. So what happens if you do a flapless procedure and you go guided, or you just go with a burr through the soft tissue, is that you're basically eliminating that incredibly valuable keratinized gingival margin, which you need, again, for health, which you need for thickness, and which you need for aesthetics. But again, if you can satisfy that your patient's implant site or future implant site has sufficient keratinized gingiva in the right location, and that your flapless osteotomy insertion and implant insertion is lingual or palatal to the mucogingival line, and you have sufficient bone underneath so it's safe to place an implant flapless, then by all means, it is an option.
All right, excellent. Thank you so much. That's a well answered question, and appreciate it very much. I hope the person gets what they need out of it. So the second question is, so let's talk about the idea of putting the implant 1 millimeter subcrestal in the case we have a thin mucogingival or above. And what's the protocol for this? Can you give us an example? If you want to put an 11.5 millimeter in, should we have to start with a 13 pilot drill or something else? What are our landmines that we need to pay attention to?
Yeah, so this is also a great question. So thank you to the doctor or doctors who came up with this here, because there's often this misconception that, like, okay, I diagnose thin soft tissue, and I think that's really great because the doctor obviously now is able to measure thickness of soft tissue. So that's a very good focus already. But the misconception in the mind of the doctor is that if I move my implant, so my bone level implant subcrestal by 1 millimeter or even more sometimes, I'm creating more soft tissue. And we have beautiful science, which is already published multiple times, is to counteract that thought. So by you countersinking an implant, first of all, you have the risk of losing, of course, valuable crestal bone. And secondly, the soft tissue, it doesn't really get that much thicker. So what you need to do is, again, just keep in mind, what is the biological vertical ideal position of the level of the implant? And, like I discussed in my lecture. Then if you diagnose that, like, your soft tissue is too thin, which is a good diagnosis to make, then you got to increase the thickness of soft tissue. So basically, a soft tissue graft from the palate is then going to be used to take, let's say, a ridge which is 1 millimeter thick in soft tissue to a ridge which is 3 millimeters thick in soft tissue. So now what you have protective barrier of, and first of all, periosteum, connective tissue, and epithelium, which together is about 3 millimeters, which is the biological width around teeth and around implants. And then you can vary where you're going to place the implant. I mean, if for the vertical biological position, for a future aesthetic outcome, you want to go subcrestal because the depth subcrestally will be 3 millimeters from the implant to the gingival margin. Perfect. And you just sink it a little bit, like you just said, instead of going with an 11.5 millimeter osteotomy, of course, you have to go an 11.5 millimeter plus however much you're going to subcrestally position. And the same the other way around. So if you don't have enough vertical crestal bone, you still want to create enough soft tissue to start with, so you have more soft tissue thickness, again, for the biological height of soft tissue, so the 3 millimeters. And then if you're missing bone at that crestal area, you're going to be doing a vertical GBR, so you can gain bone in the crestal direction, like I showed you in the lecture.
That makes a lot of sense. Excellent. So question number 3. Are there any alternatives to PTFE that you would recommend? And can you use nylon sutures or other resorbable sutures when you're doing these kind of activities?
Okay, so those are kind of very technical questions, and obviously, like, you know, that's very important. My favorite and let's say most user-friendly suture, definitely for any kind of grafting that I do, especially bone grafting, so GBR, is the PTFE monofilament suture, and that's a cytoplast. Now, they are again very good because, you know, you can do really a primary closure over an advanced ridge augmentation site, and they're even like a little bit elastic, so they will let a little bit of looseness happen in that flap, because not every flap heals, you know, without swelling. Some flaps even have some bleeding, you know, within the first 24 hours. So there's different things which happen to the flap that you can't have a suture just like rigidly connecting that together and not allowing the soft tissues to move at all. So PTFE definitely is my favorite suture for those kind of procedures. Now, nylon is great suture. I have no problem with that. It's monofilament. The only problem, of course, is that it's very rigid, and it has very little elastic properties to it. So I use it more for areas which kind of show very little potential for swelling. They show very little potential for, you know, tension on the flap. And I use it always like in a small diameter, so because they're a little bit more rigid, that they don't push against the mucosa of the patient's lip, because it often gives you some ulceration. So it's a nice alternative, but I wouldn't use it for GBR procedures on the crestal primary closure. We didn't talk about silk. So silk I don't use. I leave that up to, like, you know, other industries to use that for roping something. And I'm being, like, you know, jokingly here saying this.
Yeah.
I don't have any silk in my practice.
Okay.
Neither do we teach it in our institute.
Sure.
Third option is resorbable. Resorbable, I think, is very important, especially when you do a lot of mucogingival procedures for soft tissue, because you sometimes, you know, have to do an apical repositioned flap. You sometimes have to do a periosteo suturing technique, and those can be all like deeper, and of course also have a really difficult time to remove it. So I do that as well. And there's a German company today which I use. It's called Resorba, and Resorba is really great because it's actually as a monofilament resorbable suture, and the commercial name is Glycolol, and that kind of is one of the alternatives I have.
Okay, very good, very good. So the next question that came in is, what is your view on using PEEK Pecton as a screw retained abutment, and how does it perform clinically? Are there any advantages, or are there some other abutment options that you prefer?
Okay, yeah, that's another good question. Audience has really been paying a lot of good attention, so thank you. With the PEEK abutments, you got to remember that, like, from our scientific background, most of the work that we have created, and most of the work that we have followed in the scientific academic environment has been focused on, of course, titanium, has been focused on maybe some gold alloy, although that's becoming a little bit old school, and zirconium. The PEEK abutments have really not been studied from a clinical perspective to a large amount. They have entered the implant industry mainly because they came out of orthopedics. And of course, some industries in the dental implant industry saw it as an option to create maybe like something which is user-friendly, can be adapted pretty easily, and maybe also like efficient in price. But to give you my scientific background, I don't really see this abutment as a viable abutment for dental implant restorations or to cross over the soft tissue margin. And I maintain in my practice really only two options. One is the titanium option, abutment option, and the second one, of course, is today usually a custom zirconia abutment, which we create after we take a bone level implant impression. And usually we do that zirconia abutment with a titanium insert.
Okay. Are you doing any of this with intraoral scanning and then CAD/CAM manufacturing, or is it all, how are you doing that?
Yeah, we have all the scanning abilities here in the Institute.
Yep.
So we have definitely moved into the directions of digital scanning, digital software planning, of course, cone beam CT scans, which then gets analyzed prosthetically, where's the tooth position, like I showed you in the lecture. So definitely, have we replaced, traditional techniques 100% with digital? I would say no, not yet.
Okay.
But there's, it's definitely moving into the direction. So for any of the young dentists and the younger generation who still have the opportunity to learn a lot and to see where the industry is going, I think the more time and even budget you spend on digital, the better it is right now.
Okay. All right. Well, that sounds good. All right. So we're kind of going to step back a little bit, and it goes to some of the questions before, but I think these are still important questions to ask that came in. And if you're going to look at the most important biological foundation for soft tissue surrounding an implant, what to you is the most important part of that? What is the most important foundation?
I think from a standpoint of soft tissue health and soft tissue maintenance, there is really one criteria which we need to focus on. That's the bone. And that's why when I think about all my long-term cases, which are 20, 25 years in follow-up with stable crest of bone and stable gingival margins, is number one is that we have always focused on guided bone regeneration to be a principle, a biological principle, and also a clinical step how to thicken bone around implants. So when you look at all of our older cases, it's always kind of the same. They have about 2 millimeters of buccal bone. That's our goal. They have sufficient bone all around it. That's also important, and that's really what keeps their healthy soft tissue height. Now, then, of course, also because I'm classically trained as a periodontist, I think there was always a very heavy emphasis in our GBR procedures when we were creating bone, and we're creating bone today, is to always make sure that we have that soft tissue thickness, which we know today that is necessary to be at least 2 to 3 millimeters, and that we have always had this keratinized gingival margin, that an implant restoration is always surrounded with thickness of soft tissue and also qualities. So that's really, really important. And I always say, in clinical lectures, there's no patient that I can control after I'm finished with all the work that we have promised the patient to do, and the patient is happy, that leaves this office with mucosa around an implant restoration. They're leaving the office with keratinized gingiva. That's the goal.
That's the most important thing, right?
Yeah, then I supported, of course, what I said first, with a thick, bony foundation.
Right. Okay, yep, understood. Okay, so to get what you just said, every patient you want to walk away from, what is the ideal placement of the bone level implant to be able to achieve what you want to achieve?
Yeah, so that's when you looked at the lecture, that's what we call today the biological height or biological vertical position of an implant. And I actually published that in 1997, 1999. So that goes 20 plus years ago in some of the clinical journals at that time. And basically we duplicate the range of soft tissue that you see around an implant abutment when it like progresses through the soft tissue. There could be a one-piece implant, there could be a bone level implant with an abutment, but how much thickness of soft tissue is created on top of that? And the range is about 3 millimeters plus or minus. And that's kind of where we are. So when you're placing an implant, you always have to backtrack, and you saw it in the lecture. So decide in your mind, so be smart about it, with the technician possibly, is decide in your mind, is the implant crown that you're going to create for this patient probably doesn't have bone enough and doesn't have soft tissue enough. But you know from your diagnostic wax up, that could be like digitally or analog, where is the ideal gingival margin, because you have the remaining teeth. And then you will go 3 millimeters below that ideal gingival margin, and that's where you're placing the head of a bone level implant. And that is where it's going to be decided now. Is the crestal bone available? You're fine, perfect. Implant is just simple, placed at the crest. Is the bone deficient? You place the implant superior, and you have to do a GBR. Is there too much bone? And sometimes we have these patients which have too much bone. You place an implant slightly subcrestal, but you're always keeping that 3 millimeter range in mind. That's the bone level biological concept.
I got it. Okay. So it's based on a case. It's not just an overall concept. It's based on the case that you have.
Correct. Yeah. And I'm talking, of course, mainly about aesthetic implant restorations.
Sure.
Sure. As soon as you go into edentulous restorations, or you go into like posterior molars, you know, like the position of the gingival margin is not as crucial as if you're working in the anterior maxilla.
Sure, absolutely. Especially in LA, right?
For sure in Los Angeles, yeah. Although nowadays nobody matters, because we in California we're wearing face masks.
Oh, right. Doesn't matter. Perfect.
Right. That it's a concept which is maybe different in other states.
Right. Good point. All right. So this next one is on temporary restoration. So what's the optimal time for you to start shaping the tissue? Is it right during surgery, or do you like to wait a little bit? What are you looking at?
Yeah, good question here. So that because that has changed a little bit. So again, in the older days, so the some days before, you know, often a prosthodontist or a restorative dentist or an aesthetic dentist try to shape the gingiva by placing a temporary restoration with an abutment, some kind of abutment on and off, and then reshaping the embrasure space a little bit, adding some composite or taking some composite off or acrylic, and trying to manipulate in this way the soft tissues to get the best height and gingival level. But that was, of course, like, you know, quickly seen that was actually more disruptive to the connective tissue than positive, because every time you take an abutment off, especially when you go all the way down to bone level, you're disrupting periosteum, you're disrupting, again, collagen fibers, and you're disrupting epithelium. So that, you know, we then changed, and we went more to like an one-time implant restoration, temporary placement, with an one-time final abutment placement. And because in my practice, we mainly do bone level implant, and that's what we mainly teach, is like you want that implant bone level to be connected to an abutment and just leave it there uncovering. You don't want to disrupt this anymore. So if you need to take an impression, you take the impression, you know, in the collagen fiber space, not in the periosteal space. So you take in the connective tissue, or maybe even in the epithelium, which is the least vulnerable, least delicate. So our goal is today is take an impression of the implant bone level as early as possible, or whenever you place the implant. Then you have time to create the bone, that's your GBR. Then you have time to let the implant osseointegrate, that's your healing. And then when you come back to uncovering, you do a mucogingival procedure And the goal at this time is to place the final abutment and a temporary restoration immediately. So at uncovering. And the temporary has the full contour of the final tooth. So now the soft tissues can be guided around the embrasure spaces, around the final abutment, which is usually zirconia in the aesthetic zone. And then it again can create a real nice maturation and thickness that you can get this soft tissue.
I think that's a really interesting answer that you gave, especially what was once thought and now what you're doing now. So I think that, and that's not that long ago, right? I mean, this has happened recently, right? I mean,
yeah, I mean, the one time one abutment placement, the research definitely came out in the last, let's say, 5 years max.
Yep.
For those of us who have always been looking at biological implant positioning, we have always focused on the soft tissue,
yeah,
and also on this very disruptive way of going in and out restoratively with impression copings towards the implant head. And then also the very disruptive way of using some kind of temporary abutment, which possibly is not the material that we want. Like, you know, you probably remember the time when we had plastic abutments. I mean,
right.
It was a nightmare because they didn't fit. And, you know, like, of course, biologically speaking, the soft tissue just goes, whoa, what is this?
Right.
I don't want to be around this. And the bone is going, well, you're sticking a piece of plastic into my valuable, you know, mineralized tissue. No, I don't want that.
Yeah.
And so you get bone loss.
Yeah. Yep. Well, we've learned, and now we move on to different things. So that's a good thing. So the last question that we have is really based on the papilla, which you've kind of talked about a little bit, but it really is, which anatomic area creates the most predictable papilla in a single tooth replacement procedure?
Yeah, so again, it comes down to, like, in a single tooth procedure, of course, you got to have enough bone around an implant so you can maintain that 3 millimeter vertical height, right? So you don't want to place an implant super deep, which you sometimes see in x-rays. You look at an implant, you go, oh my God, it's placed half at the position of the adjacent root. So again, stick to the same principles like I just outlined, 3 millimeters plus or minus apical to the ideal soft tissue margin. But then in the aesthetic anterior area, especially for single teeth, of course, we have a very important part of aesthetics, and that's the gingival papilla. And you can't have a black triangle in that area because patients obviously are going to have a negative kind of feeling about that. So you need to have a bony peak. That's kind of usually how we call it, which is healthy and non-resorbed on the adjacent natural teeth. So the periodontium has to be pretty much completely healthy. If you have a periodontium which was lost because of trauma or because of disease, and actually the adjacent natural tooth has already no papilla, or really only a partial papilla, your patient needs to be aware that, like, you're really not going to be able to give them that full aesthetic outcome with a full gingival papilla, because the bone on the natural tooth has disappeared. And in the periodontal field, including periodontal microsurgery, including peri-implant surgery, we don't have really very strong scientifically based procedures to regain bone on the adjacent teeth and regain gingival papillas. So basically, you know, we could try to fill it up with some soft tissue. You can try to add some growth factors to it, but we can never give the patient, let's say, any kind of assurance that will work. So it will be more like a trial and error, depending on the patient's health, etc., and the willingness to go through it.
Understood. Well, First of all, I'd like to thank you for taking the time with us for the NYU program. It was a pleasure to have you with us. This has been an incredible week so far, and having somebody of your stature with us is always fantastic. I think this year's lineup was beautiful. So thank you so much for taking the time. Great lecture, and we really appreciate it very much.
Thank you, Dr. Urso, and also on behalf of me here from the Guide Institute, thanks to NYU for including me, and looking forward that everybody stays healthy. Yep. And that we're moving in the right direction every day.
That's awesome. Thank you so much.